Good evening, ladies and gentlemen. My name is Dr. Rayhan Haydri, and it's a great pleasure to introduce you all to the third in this fantastic educational series run in conjunction with Gastro Learning and Medtronic on the management, diagnosis, and treatment of patients with Barrett's dysplasia. It's a real honor to be able to chair this session. And so without further ado, before I touch on the program, what I'd like to do is just to introduce our two speakers. First is a good friend, but also my consultant colleague here at University College Hospital, Dr. David Graham, who is a gastroenterologist. He's also an interventional endoscopist and also the clinical lead of our division of medicine. And, you know, Dave has not only a robust background in research in this field, but has supported training and education in endoscopic therapy, particularly with his engagement with the RFA Academia platform, which he's really sort of fronted on over the last 2 years. So Dave, thank you for making the time, and really looking forward to hearing from you this evening.
Hi, Rayhan. Nice to see you. Thanks.
And, you know, a man that needs little introduction, Professor Pradeep Bhandari. Again, a good friend of UCLH, a good friend of mine and Dave's. And Pradeep has really helped to engage a lot of endoscopists in our country to train and to take on new skills in the management of not just esophageal disease, but also gastric and colorectal resection, and continues to really challenge the paradigm and not just improve himself, but take some of us along with him. So Pradeep, thank you for making the time. I know you've just returned from vacation, so really good to have you on board.
Thanks a lot. It's a real pleasure.
So ladies and gentlemen, this evening's session is action-packed, and is going to be split into two subsections. The first is going to be on the detection and resection, really, of Barrett's esophagus. The first two parts of our series that some of you will have seen really focused on non-endoscopic sampling with the cytosponge. But now we're really going to get into the nitty-gritty of imaging, detection, but then also about resection and ablation. And then the second half, we're going to, with some fantastic case demonstration, ladies and gentlemen, Pradeep Bhandari is going to talk to us about removing Barrett's lesions, managing complications. We're going to see the next powder in action. So really looking forward to that. So I'm going to now introduce our first lecture by Dr. David Graham. David's going to be talking to us about the detection of dysplasia in Barrett's. David, really looking forward to your talk.
Thanks, Rayhan. Good evening. My name is David Graham, and without wanting to sound like I have delusions of grandeur, this is the most important lecture. You need to be able to detect dysplasia in order to find lesions to treat, and you need to be able to detect dysplasia in order for your treatment outcomes to be optimal. Do we do endoscopy well? Well, the truth is we actually don't. We found in this meta-analysis, it was found that around about 11% of upper GI cancers are missed at endoscopy. Is endoscopy done well during Barrett's surveillance? Well, again, not very well, very inconsistently. This meta-analysis defined a missed cancer as a cancer that was diagnosed within 1 year of the initial diagnosis of Barrett's esophagus. And you'll find that 25% of esophageal cancers were diagnosed as missed cancers. This means a cancer was found within a year of the index endoscopy. This clearly means that the cancer was missed at the first endoscopy. Is Barrett surveillance worthwhile? Yes. It's associated with improved outcomes of esophageal cancer. It means esophageal cancer is diagnosed at an earlier stage. It means your patients will survive longer, and there's lower cancer-related mortality. We need to be able to do this well, and we need to be able to improve our dysplasia detection rates. there's a feeling amongst people that, well, as long as I take my biopsies, things will be okay. That isn't true. There is a generally poor compliance to the Seattle protocol. There's a huge variability in practice. And even if you do take your Seattle protocol biopsies beautifully, then actually you're only sampling around about 3 to 5% of the surface area of the Barrett's esophagus, which means actually your chances of picking up dysplasia are quite low if you don't look and take random biopsies. Yes, there are things like the Watts brush, which is we're beginning to see in clinical practice, which may address this issue, but it is definitely no substitute for looking. So quite simply, how do you detect dysplasia? You need to look. And this work by Pratek Sharma's group demonstrated, and perhaps unsurprisingly, the longer you look for, the more likely you are to detect dysplasia. And this showed that you should be spending at least 1 minute per 1 centimeter of Barrett's esophagus. And I'm going to show later what that looks like. It's not a static process, but it's important we remember you need to have dedicated time in your endoscopist to do Barrett surveillance, and you need to take your time. Where do I look? Well, obviously the answer is everywhere. But if you really must sort of focus in one area, I suppose the most common place for dysplasia is between the 12 and 6 o'clock position. And so really focus on that right wall if you must, only look in one place. But of course, we see dysplasia everywhere. Importantly as well, you must not forget to inspect the gastroesophageal junction in retroflexion. And I'll demonstrate this in the case I demonstrate later on. So what am I looking for? And this is something we teach very badly. So there are gross signs of dysplasia. These are asymmetry of the wall, meaning that as the esophageal wall peristalses, one side or one area may not move as well as the other. You'll see nodules, and these don't have to be big lumps. These could be subtle nodularity on the surface. Ulcers, always presume they can. If you see an ulcer inside Barrett's esophagus, presume that's a cancer and biopsy, and ask questions later. Areas of friability are often also a sign that there is dysplasia or cancer lurking beneath. And then we talk about the more subtle signs of dysplasia, and this is where you see the subtle mucosal and vascular pattern changes that we'll talk about briefly now. But also there are color sign changes as well, which is an important part of the classification system added recently. So I'm not going to labor this point. We can put the papers on the platform below in the resources sections. You can look at these, but there are a variety of classification systems that have been published. There's classification systems for narrow band, for iScan, and for BLI. These are the three major, Olympus, Fuji, and Pentax are three major sort of scope manufacturers, and they all have classification systems. I'm going to look at the BLI one, called the Blink classification, just here briefly, because actually when you read the classifications, they're all basically the same. You're looking for, are there color changes? So when you switch on your image enhancement, be that narrowband, iScan, or BLI, is there a color change that you note? You're looking at the mucosal pattern. Are they irregular, what we call amorphous, where there isn't a mucosal pattern? Is there an uneven distribution of the pits? Or are they regular, almost like brain matter? If it's regular like brain matter, it's non-dysplastic. If the amorphous, irregularity, any of those things exist, it's neoplastic. Take a targeted biopsy. Similarly with the vascular pattern, are they regular blood vessels you see, or are they dilated, friable, branching, neoplastic? Please look at these classification systems, but the important thing is to take targeted biopsies when you think you see dysplasia. A really neat trick and incredibly helpful is to always use a CT CAT scan. You should be using this for all your Barrett surveillance. It doesn't take long, it's cheap, and it's invaluable. This meta-analysis published in 2016 demonstrated it had great sensitivity and specificity levels for picking up dysplastic lesions. And I'm going to show an example later on, but simply you spray acetic acid, the Barrett's goes white. Areas that lack acetyl whitening are areas you should be suspicious for dysplasia. There's also a publication on the classification system using acetyl whitening published by Pradeep, who's here with us tonight. But I mean, essentially it's the same thing, but adds in the acetyl whitening aspect. So I wanted to show you now what Barrett's esophagus surveillance looks like. And this is me in high definition white light, just slowly going through, starting at the top, and slowly going through the Barrett segment. Once I've cleaned it, you can use saline, N-acetylcysteine to get rid of the mucus, but make sure it's clean. You slowly go through the Barrett segment. You get to the GOJ. You make sure you don't over-insufflate the esophagus so you can find the top of the gastric folds accurately. And therefore, you can then start coming back again, measuring the length of the Barrett's esophagus. You can see this is a long segment of Barrett's, and I'm going to be measuring the Prague classification as I come back. But I'm not just doing that, I'm also looking left and right, up and down, looking to any areas that concern me. And you can see here on that left wall, around about 7 o'clock, I can see a slight color change, a slight vascular abnormality, and my eye is already drawn to that area. And I go back and forth. Now, this is an edited version of this. Isn't just one, I don't just do one pass, but I wanted to give you an idea of this. I then switch on my image enhancement and do the same thing. I go back and forth, up and down the esophagus a few times in this process, looking at the walls. And again, you can see my eye is drawn to that left wall. There's a color change down that left wall at 7 o'clock, and the mucosal pattern, the vascular pattern, doesn't look quite normal. When I'm doing these passes up and down, I will also do the retroflexion movement inside the GOJ that I'm going to demonstrate shortly. But you can see here that my eye is still drawn to the left side. You can see at this 7 o'clock position, that vascular pattern, that mucosal pattern looks subtly different. And that is why, that is something that isn't an obvious sign of dysplasia, but it's something that's very important. Now you can see now I have my dye spray catheter out, and I'm now going to spray the Barrett's esophagus with acetic acid. We use 2.5% acetic acid. Once it is sprayed, it starts working very, very quickly. And you can see the Barrett's esophagus walls almost immediately turned white. And you'll notice a big patch of unstained air on the right side here. If you remember, that's the big squamous island. So that's not an area that lacks acetic whitening, that's the squamous island that we saw at the start. But what I'm doing now is I'm going back through, up and down the Barrett's esophagus, making sure I can see if there's any change. You can see once you've got acetic acid, you can see the mucosal lining beautifully. You can see the regular pattern of the pits beautifully. Here, I'm demonstrating a maneuver to look at the GOJ. So you should always be retroflexing into the GOJ. You see, I'm pulled right up into the GOJ here, and I'm pulling the scope right up, switching on my image enhancement. Again, you can see that beautiful mucosal pattern there. And I'm just rotating the scope around the GOJ to look to see if there's any mucosal or vascular abnormalities. This maneuver has to be done every single time. And you'll now see as we come back that area that my eye was caught to, that left side, that 7 o'clock position, has lacked acetyl whitening. You can see beautifully here that there is a patch there with no acetyl whitening. This is dysplasia. Now, this is a beautiful next case. You can see on this sort of 1 o'clock position as we come back, there is nodularity. We then spray the acetic acid, and suddenly you'll notice that actually using acetic acid, there is a patch there at 7 o'clock that has lacked acetyl whitening. But that nodularity at 1 o'clock, you'll note actually has acetyl whitening. And actually, when you look at the overlying mucosal patterning, the mucosal pattern is normal. That nodularity was biopsied because it's always best to be cautious, but actually was not dysplastic. That patch that lacked acetyl whitening that we couldn't see any abnormalities with, particularly initially, was a cancer. So it's hugely important to take your time, but also use all the tools available to you. You must use an image enhancement, and really you must be using acetic acid. And that, ladies and gentlemen, is really my brief presentation on how to detect dysplasia. And of course, I'm happy to take questions, and we'll discuss this further with Rehan and Pradeep in the studio.
What a fantastic lecture, Dave. You know, actually just concentrating on how we do the basics right, it makes such a big difference. Now let's, I'll pull in Pradeep in a second, because I just, you know, we've reflected on your slide that you showed, showing that we are still missing lesions. So clearly, you know, you've shown some really good tips and tricks on imaging, classifications, acetic acid, etc. So, you know, just a couple of questions. First of all, why are we still going wrong? And also, two, what's the role of the simple things like, you know, preparing the esophagus and sedation? Talk to me about sedation. In the UK, we still seem to be slightly averse to sedating all our patients for upper endoscopy. So 2 questions. 1, why is there still a gap? And 2, how can we improve the quality of our endoscopy, except for imaging, the non-endoscopic factors?
Thanks, Rehan. Great question. So, I mean, I think the answer to your first question is education. I think predominantly, I know that that there are developments that we're going to probably talk about, I'm sure, at some point imminently, in technology, but actually, really, there's really poor education about how to spot dysplasia. It wasn't until I came to my, registrar job at UCH, a twist of fate brought me here, and someone actually said to me, by the way, do you know what dysplasia looks like? And I had no idea. No one had ever actually said to me, look for a nodule or whatever else. We really don't teach people how to look for lesions. So education, webinars like this, going online, all these things are fantastic. And that's really, I think predominantly why we're missing lesions is simply we aren't educating people and we aren't dedicating sufficient time for looking. And that kind of comes on to your second question is, sedation. I remember doing Barrett surveillance lists, at other hospitals where, 10 patients were put on like a normal endoscopy list, or, you were asked to quickly do a colon afterwards. And, you just, put the scope up and down as quickly as you could because that's what I thought we did. And it wasn't until I realized that firstly, you cannot do a Barrett surveillance case with a patient awake unless they are unbelievably stoic. They know they won't sit still long enough for you to do a Barrett surveillance case. They need to be sedated. We use scarily high for some people's levels of sedation, high levels of midazolam and fentanyl, 5 and 100 to sedate people properly. And of course, in Europe and the US, they use propofol, but you need sedation to do this properly. And then as you say, clean the esophagus, take your time.
So Dave, that's really, sound advice. Pradeep, let me ask you a question about a very topical issue at the moment, which is artificial intelligence. And, now we have in most of our units, commercially available units, platforms for supporting polyp detection. We've got randomized data. It's all right for people like David and you that are experts. You can find a needle in a haystack. But what about, the others, the likes of us that are doing this, in a challenging environment where we haven't had, the investment in training that you have? Is there going to be an artificial intelligence solution for Barrett's, do you think?
It's a very good question. I think that's where the future is heading. But before I answer that question, Rehan, I was just listening to a discussion between you and David. One of the thoughts that has always come to my mind, which sounds very controversial, but I would still air it. I feel it is time now that Barrett surveillance should be declared as a specialist endoscopic procedure. It should only be done by people who have special interest on the dedicated list. It should not be done randomly by everybody in your department. Everyone can do gastroscopy and everyone can take biopsies, but that's not what Barrett surveillance is about. And I think that the first thing we need to start thinking, at least in a country like UK, where we have these systems in place for bowel cancer screening, now happening for IBD, it should also happen for Barrett's. And every hospital can nominate a couple of people who will take special interest, have dedicated lists, and all these things will begin to happen. So I think we should focus on that. Coming to AI, I think AI is the future. AI for colon is already happening a lot. AI for Barrett's is coming really fast. There are at least 2 CE mark devices out there already available commercially. The big thing about AI is it will reduce this disparity or the lottery that patient faces. He ends up on my fellows list who's never detected a Barrett's neoplasia in the last 5 years, or ends up on my list. The outcome for the patient will be different. And that's what AI will do, is standardize that. So it doesn't matter on whose list you end up, there will be a reasonable degree of performance. Still, the quality will matter, the skill will still matter, and the endoscopist decision-making and skill and lesion recognition will still matter, but still AI will improve the quality. And it's very easy. And the big thing to me is we have spent far too long doing random biopsies, so-called Seattle protocol, so-called this protocol. Nobody follows the protocol. People just take some random biopsies and we miss. So why don't we just give that up and go for targeted biopsy?
Yeah.
Now, whether that is with acetic acid or whether that is with AI, whichever comes first with good evidence, that's where we need to go.
Yeah, fantastic. Thanks for that. That's food for thought for the future. So conscious of the ticking clock. So Dave, we're going to work you again. Now what we want to hear about from you is an update in endoresection in Barrett's dysplasia. So, looking forward to your lecture on endoscopic resection in Barrett's. Over to you, David.
Thanks. So on to our next lecture, where we discuss endoscopic mucosal resection in Barrett's esophagus. And actually, the first thing we must say is that endoscopic therapy in the treatment of Barrett's esophagus works. It's hugely successful. These are the data published at the end of the AIM dysplasia trial at 5-year follow-up. And you can see that the endoscopic therapy had a 97% success rate at 5 years of clearing dysplasia and a 90% success rate of clearing metaplasia in patients. Hugely successful. And this is data published from our own UK HALO registry. And you can see that actually what we found that over time, our dysplasia clearance and our metaplasia clearance was hugely benefited from increased EMR. What we found as we learned is that visible lesions must be resected prior to the use of radiofrequency ablation. Okay, and that is the most important message in regards to resection and RFA as well. And we demonstrate here nicely in our study that as we use more EMR, our outcomes are better. And it's important also to say, and this is early data published by Oliver Peck, Oliver Peck's group, that EMR is safe and it's effective. These are 1,000 patients who are followed up over 5 years, and you can see that their response rate was hugely successful, their recurrence rates were low, and the complication rates were very low as well. Only 1.5% in this group had bleeding or a perforation. There were, of course, some minor complications such as stenosis. And this is more recent data looking at the use of EMR in Barrett's esophagus. And this is a meta-analysis published actually only about a month or so ago, looking at 14 studies, 1,400 procedures, almost 1,000 patients. And again, you can see that the complication rates are low. In this meta-analysis, the bleeding rate was 0.2% immediately and 0.7% delayed bleeding. Perforation rate was low at 0.3%, and strictures were only found in about 4%. Now, they do draw attention in their own analysis, but I have to say, I think that stricture rate is probably low. It's very dependent, we know, on how big of a resection you're doing. If it's just a focal area, yes, your stricture rate is quite low. But of course, if you're doing a large area, particularly if it goes over 50% of the circumference, your stricture rate is much higher than that. So I think that's possibly underreported in this meta-analysis. But importantly, it is to say that stricture rate is not too high that it's unmanageable. And again, in this meta-analysis, you see that the successful resection rate is around about 98%, with R naught in 94%. Now, we're going to discuss later when Pradeep presents about what is the role for ESD in Barrett's esophagus. It's a very fashionable thing to talk about that. It's something that we all like to do, but actually the real emphasis I want to lay on EMR right now is we've been doing it for years, and in the vast majority of patients, it has worked hugely successfully. So, and I'm sure Pradeep will agree with this in his talk later, we should not be just thinking, oh, well, ESD is better, we should ESD everyone in Barrett's esophagus. Different conversation for squamous neoplasia, but in Barrett's esophagus, ESD has a role in a subsection of patients. EMR is certainly adequate in the majority. And therefore, I wanted to show you in this video how to perform an EMR. And there are a few challenges that I faced when doing this EMR that I hope to talk about. You can see here, again, a bit like we talked about in the dysplasia detection video, this is a subtle lesion. You see here, there's friability, and the areas lack acetocyte whitening as well. You can see the surrounding mucosal pattern is normal. So this is it's the patient with a very subtle area of dysplasia. And you can see there's subtle nodularity, there's a lack of acetowhitening. So the first step to form an EMR is to mark the area. Even if you think the dysplasia is barn door and obvious, always mark. It is amazing how quickly you can lose your fields. The way to mark is to use the snare tip and just literally bring the edge of the tip out. You mark using soft coagulation, and it's important that when you're marking, you just lay the tip of the snare onto the surface. Don't dig it into the esophageal wall, because that's when perforations can happen. So all you're doing there, you can see if you haven't got a good position, don't press the foot pedal. You're using soft coagulation, as I say, 40 watts should be fine, and you're just laying the pedal onto the surface and then going around the lesion to mark. This is a hugely important step. Remember, the marks for you. You want to resect outside the marks to have complete resection. You can see here we have a nicely marked lesion. We've then placed the EMR device on. In this case, it's the Cook EMR device. Of course, there is also the Boston captivator, which you can use. You then suction the lesion into the scope and apply your band. And you can see you create this sort of pseudo polyp here with the band applied. Now you can see here that this patient had quite a lot of mucus. And so actually it's important you wash your scope, wash the area, make sure you have good visibility. This is an important step. Now, we're now going to start trying to place a snare around this. And the best way to do this is to position yourself above the pseudo polyp, as I am doing here. It's often good to get right on top of it so that you can then bring the snare out over the pseudo polyp, like I'm demonstrating here. Once you've got the snare out over the pseudo polyp, as happens here, you can then just simply bring the scope back over the polyp, which means the snare will nicely go over the top. And you can see that's done here. Then put the nose of your scope down and push the snare tip out into the base of the pseudo polyp. Now you can see here that actually as we push the snare tip down, it was slightly tricky to get position. Ideally, I'd have had a nice visibility of the snare tip going under the elastic band, but I couldn't quite get the position here. And this happens, this is real life. So you see, as we close the snare tip there, it's closed above the elastic band. This isn't acceptable, although there is conflicting data about this, but you should aim to sit below the elastic band. So therefore, when this happens, just release the snare slightly, bring the snare towards you, and reposition so you get yourself underneath the elastic band as demonstrated here. So now we know we have a very nice snare position. And you can check with the nurse or whoever's holding the snare to make sure it's not what we call bouncy, where the back of the snare is on the elastic band. They want to make sure you have good contact. You then over-insufflate the esophagus. This step then allows, if there are any muscle fibers you happen to have caught unbeknownst to you, this over-insufflation will hopefully push those muscle fibers out of the snare. However, don't stay over-insufflated, then suction down so the esophageal wall is not tense, and therefore you can potentially increase your perforation rates. It's now time to apply your heat. Now, everyone has different techniques for this. The way that I do it is I found that if I was going to get bleeding, it's often the edges of the lesion. So I will do 3 seconds on the coagulation, which means that the edge of the lesion gets extra coagulation. I'll then tell them I'm going to change to cut, and I'll do 3 seconds on cut to come through the lesion. And you can see there's a lot of mucus here, but by doing that process, I find I get good cutting and also no bleeding. You can see we've now inspecting our base here, and you can see this is an area that's beautifully resected. You can also see all the dots have gone, which means that I'm happy that actually just in one EMR bite, I've taken the lesion. So let's go back to Pradeep and Mehan now, and we can discuss further the benefits of EMR, technique of EMR, and perhaps we'll touch perhaps on other resection techniques.
Thanks, Dave. Some fantastic tips and tricks there. So, we'll talk a little bit about the devices available in your strategy, but that meta-analysis from a few weeks ago is reassuring, but the stricture rate is low. Now, in your practice, do you resect just the most horrible part of the lesion? Do you resect all the lesion? Do you take out all the Barretts? What's your advice to people on the line in terms of what to take out, what not to take out?
Yeah, I mean, I think there's probably like an hour-long lecture in that question itself. There's quite a complex answer, but I think the very easy thing to say is all visible dysplasia must be resected. So that's, so it's not acceptable to go, I'm just going to take the lumpy bit out and I'll leave the little noduly bits or whatever else around it. No, every bit of visible dysplasia has to go. That's the acute cancer risk. So that's what I'd say first. I think the second thing is about, what devices do I use and how do I go about it? I think firstly, if it looks like it's a massive lesion, because we get these sometimes, we get these whole bits of Barrett's that all looks nodular, as I've, and I'm not as old as you two, so I can, but I'm, not far off perhaps. As I'm getting older, actually, I'm quite happy to go, do you know what? I'm not going to do this on sedation today. I'm happy to back down. I'm going to make sure this patient comes back for general anesthetic. Don't be afraid to say, this is a big relief, this is a big resection to do. Just let's put this in on the proper sedation another day. And then when it comes to device, I think, use the device, I guess you're comfortable with. Most of my EMRs are done with the Cook device. So I'm very used to using that. So I do tend to reach for that first. In saying that, the capture device I like a lot as well. It has the elastic bands put behind the scope view, which is great, which have better visibility. So I do reach for the capture device not infrequently as well. But really, I think that I guess the answer to your question really is just resect it all. And if you're resecting over 50% of the circumference of the Barrett's, the patient is going to get a stricture. That meta-analysis is too low, that stricture rate. The patient will get a stricture, and you need to either think about, do I place a prophylactic stent? Do I bring the patient back for dilatations, in a weekly, 2-weekly basis? Have that in your head straight off. I don't know, Pradeep and Rehan, I guess to you, there was a vogue about using steroids at one point, wasn't it? Giving people a prescription of steroids after a big resection. That's gone away now. What's your view on steroids?
Pradeep, your take on steroids as prophylactic stricture management?
Well, the debate about the steroid has been for last 10 to 12 years. And people have reported, some enthusiasts report very good data. When you talk to people who actually use steroid, like Stefan Sewell uses steroid regularly, and he says the response is very patchy. In some patients, he doesn't see, he only needs to dilate twice. In other patients, he needs to dilate 6 to 8 times. And I have to say, I've been doing this since 2007. I've never used steroid at all so far, purely because I've seen various case reports of mediastinitis, patients getting severe mediastinitis after steroid injection, deaths, and debatable outcome data. What we do is you anticipate that and you do prophylactic dilatation very early. And that strategy as well. I just want to see some good data comparing steroids with prophylactic dilatation to see what will be the best way forward. So just because of the side effect profile of steroid and lack of convincing data, we don't use, but doesn't mean that it doesn't work. People who use, they report good outcome.
Food for thought, and maybe we can pick your brain on that when you talk about ESD. So let's move away from endoresection now on to ablation. And Dave's now going to just give us a lecture on the updates in radiofrequency ablation in Barrett's esophagus. So Dave, your final lecture.
Thank you. So on to our final talk on radiofrequency ablation in Barrett's esophagus. Now, before we start any talk about radiofrequency ablation, we have to say again, I'm sorry to be boring, resect all visible dysplasia prior to undergoing radiofrequency ablation. This is vital for your patient outcomes. Okay, which patient should receive radiofrequency ablation? Essentially, it's any patient with confirmed dysplasia on biopsy. And this has to be confirmed by an expert histopathologist. We'll discuss later about low-grade and high-grade dysplasia, but this is a brief summary. Now, of course, I'm going to say it again, you only apply radiofrequency ablation once you've resected the visible dysplasia. So it's important to think about, well, why is that the case? And I like to think of it that when you resect the visible dysplasia, you're sort of resecting the acute cancer. That's the bit right then and there that is going to cause that patient to develop cancer. After you've removed that immediate threat, then the rest of the Barrett's esophagus that is present is essentially a pro-oncogenic field. We know from studies such as the AMC marker study that if we biopsy that entire Barrett's area, even though the rest of it doesn't look dysplastic, it has the oncogenic changes that means it will develop cancer if we leave it long enough. And this lovely study demonstrates that when we biopsy those areas prior to radiofrequency ablation, performed radiofrequency ablation to eradicate the Barrett's esophagus, and then re-biopsy those areas, those pro-oncogenic abnormalities disappeared. So that's why you're ablating. It's to ensure that the long-term recurrence risk, the long-term outcomes are great. So resect for the immediate threat, and then radiofrequency ablation takes away that long-term risk. And in short, as we talked about earlier, it works. The results of the AIM dysplasia trial, as published here, and other trials show that the outcomes of endoscopic therapy, which is resection and ablation with radiofrequency ablation, have brilliant outcomes. 97% of people clear of dysplasia, 90% clear of metaplasia at 5 years. And again, just emphasizing this data again from our own UK HALO registry, we had great outcomes in the UK, 92% dysplasia eradication, 83% metaplasia eradication. That's in real life data, so outside a clinical trial. But importantly, those outcomes came when we resected visible dysplasia first. The other thing to remember, and this is important, of course, is that radiofrequency ablation is safe. We see that the stenosis rate is somewhere between 8 and 12%, probably lower for the focal devices we'll talk about later, higher for the circumferential devices, but around about that 8 to 12% mark. Doesn't mean that every person has retractable strictures. Of course, the vast majority we can dilate and improve. Bleeding rates are very, very low. In fact, in real life data, it was less than 1% for us. Perforations are almost non-existent. Laceration don't really mean anything, I think, in real clinical life. And hospitalizations is something we very rarely see now. This, I think, was early on when we were first learning the technique, but very rarely are patients hospitalized now. Even in this data, it's less than 1%. So how do we apply radiofrequency ablation? Well, essentially, at that initial endoscopy, if you see the dysplasia, you should resect it using EMR. We talked about that earlier. If you can't see any visible dysplasia whatsoever, then you should be aware that has the dysplasia definitely be confirmed by an expert histopathologist. If it has, you're fine to start radiofrequency ablation for that patient. If it hasn't, then I can't see any dysplasia, then I would just re-biopsy. Once that initial endoscopy has happened, and normally I have to say, over 95% of the time, you'll see dysplasia, and therefore that first endoscopy will often be an EMR. You then bring the patient back 2 to 3 months later to commence RFA treatment. And essentially, if you at that repeat endoscopy find an EMR, find an area of visible dysplasia, perform an EMR again, and that counts throughout the treatment algorithm. But if not, and it's all flat, then you can start RFA, and you basically choose your device, which we'll talk about later, according to the Barrett's length. Once you've given RFA at this event, you then bring the patient back 3 months later to have further RFA to any residual Barrett's dysplasia. The average person needs about 3 treatments, and the important thing to remember is that every time you apply an RFA, you should always ablate the gastroesophageal junction. This improves outcomes. After each time you apply endoscopic therapy, be that EMR or RFA, ensure the patient is on adequate acid suppression, high-dose PPI, an H2 antagonist if you can get it, and a bile acid sequestrant such as sucralfate as well. Make sure they take that. So what are the RFA devices? And something that we don't talk about, we always talk about efficacy and safety when we talk about any procedure, but RFA is actually, and this is the key point, actually quite easy to do. And this is where these devices have been developed really well. It's quick and it's easy to do, as well as being safe and efficacious. And one of the things that makes it quick and easy to do are the range of devices we can use to treat the Barrett's. So we have the circumferential device, which is the HALO Express. Now, this is a really quick procedure now, particularly because the Express device taken over from the 360 balloon has this self-sizing balloon. So how do we do it? We obviously use N-acetylcysteine to get rid of mucus on the surface. We put a wire down into the stomach. We then railroad the Express device onto the wire into the esophagus, put the scope in alongside it, and then simply press a pedal, the balloon inflates, and then you press another pedal to ablate the wall, and then simply you move the balloon down to avoid too much overlap. The most important thing to remember with the Express device is your dosimetry. You must do 10 joules, then take the device out, clean the Barrett's esophagus with water and a cap to clear all the burnt areas off, and make sure you take your time cleaning. This step is hugely important because it cools the esophageal wall down prior to then you putting everything back in and applying 10 joules again. If you don't do this cleaning step, your stricture rates will be very high, around about 20%. So this cleaning step must be done. Know your dosimetry. We then have a range of focal devices. Now, these are used when it's not circumferential. The circumferential device is 4 centimeters long. So if you have an area of Barrett's esophagus that's circumferential and 4 centimeters or more, circumferential device. If your Barrett's esophagus is less than 4 centimeters circumferentially, or just isn't circumferential at all, then you should be using a focal device that fits onto the scope. There's a range, again, of devices. The 90 Ultra, I use quite a lot. It's 4 centimeters long, which means you can treat long segments of non-circumferential Barrett's quite quickly. There's the 90. The 60 is very good. It's narrow, so you can use it in amongst stricture areas. And actually, I personally very rarely use the through the scope device, but it's very good for using for little islands. The dosimetry for this is different and much easier to do. It's what we call a triple 12. So simply, and you'll see this later, apply the device onto the esophageal wall, keep it in that position, and apply radiofrequency ablation 3 times. Once you've done that, remove the device and that area is treated. Now, actually, I don't want to boast too much, but there's a superb course that's run by Medtronic, which myself and Rehan Hajri are part of, where you can run a course where you get hands-on, lots of coaching, anything you need to know about giving radiofrequency ablation. And it's a really brilliant course, a 1-day course. And I really would encourage you to reach out to either you come through the platform and myself, or reach out to Medtronic and see if you can be part of it if you want to undergo radiofrequency ablation, or perhaps you just want to pick up a few more tips. Now, I want to show you some clips on radiofrequency ablation. This isn't meant to be a tutorial on how to apply radiofrequency ablation. You know, you need, as I say, a proper sort of day and course for that, but I just want to show you what this looks like. So this is the Express device. You can see we have the scope alongside the device as we talked about. You inflate up the balloon, you get good apposition to the wall, and then you ablate. You then simply move the scope and the device down. You can see that lovely area there that hasn't been ablated yet. Again, inflate, press your pedal, ablate the area. The balloon then goes down, and you move the device further down until you see the area that hasn't been treated. Again, avoid too much overlap and do the same thing. Inflate, ablate, and you're done. That's the step. Take everything out, clean it as we talked about, and then do that again. This is the ultra long device. You can see sometimes it can be tricky to intubate with, and you can use that white tube to aid intubation. Once you're in, you then simply you start at the GOJ, find the top of the gastric folds, place the pedal onto the wall, push so that your scope is fully pressed against the wall, suction down, and then stay in that position, holding the suction button, and apply it and press the pedal 3 times. That's 3, wait for the ablation to finish, another, wait for the ablation to finish, and another. And then simply you move away, that elongates the esophagus, and then you rotate your scope to make sure that you don't get too much overlap, and apply radiofrequency ablation again. And essentially you do that as you go around, and you can see it's very quick, it's easy, and you ablate the Barrett as well. And finally, this is through the scope device. There's a little paddle that comes through the scope. You can twizzle the device to get which bit of the wall you want to find. Again, you push the paddle onto the wall, suction down, push as hard as you can. And again, it's a triple 12. So 3 ablations, one after the other. Once you've applied those 3 ablations, move the paddle away, you see you have a nice device. And then again, you simply just move your scope down to the next part of the Barrett's you want to ablate, push the paddle onto the wall, and again, suction, push the scope into the wall, and press 3 times. So that's how you use the devices. We can talk more about that as we go. But really, what I want to say in this instance is that the summary is that radiofrequency ablation works. It's fantastic. Resect any visible dysplasia prior to using radiofrequency ablation. And really, the decision making here is key. So finally, well, radiofrequency is fantastic. In the vast majority of patients, you'll have no problems, but the decision-making surrounding your patients is key. The procedure might be fine, but actually there are pitfalls that people can fall in who don't have experience that then results in bad outcomes. And I'm not going to address all these now because I'm going to go to Pradeep and Rehan and pose these questions to them now, which is, Pradeep, Rehan, should I treat every patient with low-grade dysplasia? What do I do if there's inflammation on a rescope? And particularly, what do we do if you keep seeing inflammation every time you go back and you can't apply radiofrequency ablation? And finally, what do I do if there are patients who are not responding to radiofrequency ablation? That means, I've applied radiofrequency ablation on, let's say, 3 separate procedures, and there's still a huge amount of Barrett's left, and there's been very little regression. Now, these challenges don't happen often, but it's important we know the answers. So, Pradeep, Rehan, back to you. Let's discuss these challenges.
Thank you, David, for a really nice overview of ablation in the Barrett space, a really comprehensive overview. So, Pradeep, why don't I offer you the first question, because it's a nice, easy one. Should we be offering ablation for low-grade dysplasia? Yes or no, or we don't really know?
Well, I think if low-grade dysplasia has been confirmed twice, first thing is don't rush in to ablate low-grade dysplasia. There is no rush, no hurry. I think most of us would try to confirm low-grade dysplasia twice on 2 separate occasions. And if you have a GI pathologist which confirms low-grade dysplasia on both occasions, then you have a very good ground to ablate that patient, because data is good. And also, what else can you do for those patients? You're going to monitor them, surveillance. I don't think that any of that makes sense. So if confirmed, yes, I would. If there's any doubt, I would not rush in. The patient back, rescope and evaluate. Otherwise, best to ablate.
Yeah, I mean, just to pick up on that, Pradeep, the low-grade dysplasia is a very unstable diagnosis at times, in that it will regress fairly often spontaneously. So, Mo, our fellows just, submitted our retrospective data, but we know that, up to 20% of these patients will at subsequent endoscopies never have low-grade dysplasia again. So often low-grade dysplasia itself is not enough. You need to look at the bigger picture in terms of whether it's unifocal, whether it's multifocal, whether it's been replicated on subsequent endoscopies, but also, is the patient appropriate to go on a journey of RFA, which is often 2, 3, 4 treatments. So Pradeep, the next question was about, we start ablating these patients, and then they come back for their follow-up, and we put the endoscope down, and it just looks very inflamed. What are our considerations then? Do we? I'll have a view on this, but I'll value your expert opinion.
Sure. I mean, that does happen. It's not that common, fortunately, which is a good thing. But it does happen, and those are difficult patients for all sorts of reasons. You immediately know in these patients that your response rate is going to be low. They will be challenging to manage. The best thing is, again, to check for acid suppression, what they're taking, what you prescribed, are they really taking? And we would maximize their acid suppression and bring them back in 8 weeks' time to see what the inflammation is doing. And if the inflammation has healed, then there is no question and you carry on. But sometimes, even after 6 to 8 weeks of high-dose PPI, the inflammation doesn't heal. And people are giving them sucralfate and PPI and H2 antagonist and all these things. I'm not sure there's data to support any of those things. The most important thing is maximize the acid suppression, and that should do the trick in majority of these patients. Don't rush in to treat with the existing inflammation. You can delay your cycle till it has healed and then start again. And in majority of the patients, we haven't seen a problem. We managed to get over the inflammation and treat it.
Yeah, well, a really practical answer from Pradeep for those of you viewing who carry out endoscopic therapy. Remember, there's no rush here. These patients haven't got cancer, but you must not ablate an inflamed segment of Barrett's. You'll be doing the patient a massive disservice, and you will be aggravating the situation further. We also know that compliance with acid suppression is poor. If you tell a patient to take tablets, there's very good data on this that 40% of them just won't take them. So we know that the Barrett's cohort are a little bit more committed, but also you must also not underestimate the impact of a hiatal hernia in these patients. And in very few patients, which once or twice a year, as Dr. Graham and I will come across, is after 2 or 3 subsequent treatments, if there is no regression macroscopically of Barrett, if there's ongoing inflammation, if there is good acid suppression despite being on acid on PPIs that you have physiologically proven, then the hiatal hernia needs to be addressed. We mustn't forget the reason these guys have Barrett's is reflux in the first place. So that's where surgeons need to consider looking at procedurally fixing the LOS. So great answer there, Pradeep. Thank you. So let's go. We've seen David has shown resection followed by ablation. Majority of people will get better, but there are a few in whom you ablate, and they come back and it looks like you've never touched them. And then what do you do? Do you just keep on ablating and until you run out of catheters, or do you do something else? Pradeep, what's your approach? And then we'll take some questions from the audience.
I think, Rehan, I'll go back to your same point that you said earlier, which is the key here. We treat patients, we don't treat Barrett. We treat patients, we don't treat polyps. So always look at the patient. If he's a 75-year-old and you've done 2 ablation and he's got 3 centimeters of Barrett's left, why? You can keep an eye on their Barrett's. Don't be paranoid that every single millimeter of Barrett's has to be eradicated. In trial settings, yes, of course. Outside of trial settings, when we're treating patients, we need to be practical. And if it is not responding in an elderly patient, well, don't bother. You can keep an eye on that. That's the simple thing to do. You do see that in younger patients as well. Now, that's challenging. In younger patients, you don't want to leave that Barrett's behind. You do want to ablate. Again, the answer would be acid suppression, check acid suppression, make sure compliance, make sure maximum acid suppression, and smoking and all the other issues to be addressed so that acid suppression goes down, healing happens, and then you repeat. Some of our colleagues advocate that you increase the power. I have no idea if 10 is not working, how 12 will work. People do, these are areas where people don't have data, so they do whatever they feel like. The only thing which you can do is maximize the acid suppression, make sure healing. You already talked about hiatus hernia. I think that's a very important point. So consider fundoplication in some of these patients, fixing the hiatus hernia fundoplication, and that can again improve your response rate. And then alternatively, you can think of other ablation regimes or resection. If you have an island, 2-3 centimeters of Barrett's left, it's not circumferential, it's not unreasonable to change your strategy and resect it. Why keep ablating and doing the same thing that doesn't work? So I think we need to just think laterally and look at the patient and then decide the best strategy.
So thank you, Pradeep. Yes, absolutely. Explore other alternatives. Dave, just a quick question before we go on to Pradeep's talk from the audience. Thanking you for your great lectures, but also saying, can you please expand on quote unquote resect all dysplasia prior to applying radiofrequency ablation?
Yeah, I mean, it's a great question. What I mean by that is any area that is visibly dysplastic has to be removed by EMR. And what I mean by that is not just the big nodular areas. I think, and this goes back to our original data when we first started, we just sort of removed the big lumps, and actually we're now aware, and as Pradeep has already talked about, even if there's a really subtle change of mucosal or vascular changes, or there's a tiny area that lacks acetowhitening, that needs to be resected. So any bit during your endoscopic inspection, be that a big lump or a tiny area that subtly looks dysplastic, mark that whole area and remove that whole area. And then you should be left with Barrett's that has the normal regular pit pattern shape thereafter, that you can then come back another day and ablate.
Fantastic. Okay, ladies and gentlemen, now I'm really looking forward to this next lecture. I always learn a lot from Pradeep's lectures. Pradeep's going to be talking to us now about endoscopic submucosal dissection in the Barrett space. So Pradeep, I believe you're going to be sharing your screen with us. Yes. Looking forward to this. Fire away.
Excellent. Hopefully you can see my screen. So I'll talk to you mainly about ESD and complications. Hopefully we never have complications. But why ESD? There has been a lot of views on this, and there are a lot of views which support and a lot of views that oppose. And I put down there that people believe that it's a very narrow space, it's difficult to retroflex, esophageal wall is very thin, it's very vascular. I completely agree. Barrett's is an inflammatory condition. It is vascular, so there's a lot of bleeding intraprocedurally. And then the biggest issue is the biggest scare, which has stopped ESD progressing fast in Barrett's, is the consequences of complications. It is not the same as having a perforation in the stomach or colon. If you have a perforation in esophagus, the consequences of that is very serious. And that is one of the main reasons why ESD hasn't taken on in a big way in Barrett's world. And then obviously there's debate about procedure time. On the other side, you can look at the fact that Barrett's is a very straight tubular organ. So performing ESD is technically a lot easier. There's no loops, the scope is straight, access to the lesion is easy. So it's less challenging to perform ESD. And I feel that how Japanese got so good at ESD because they had such high prevalence of gastric cancer, we have a similar opportunity with Barrett's. To improve our ESD scale, we get a lot of Barrett's cancers, and ESD could be a similar thing for us where people can improve the ESD skills and get good at it. But we have to treat patients and not just improve our ESD skills, so we have to be very mindful of that. If you look at these two cases, both have Barrett's neoplasia. On the left is the old scope, flat lesion, which doing what David showed you very elegantly. On the right side, it's a slightly newer scope with a nodular lesion, and that's where we are doing the ESD. So we're doing EMR on the left side and ESD on the right side. You can see that procedure-wise, both will achieve resection of the complete neoplastic area. Here you can see both have been resected. Now we need to look at the histology. The histology here comes back, multiple pieces, cancer seen at lateral margins in 3 out of 5 specimens. Depth of invasion cannot be determined due to quality of specimen. What do we get the histology here? A single piece, cancer seen 2 millimeters from the lateral margin, clear at deep margin, depth of invasion 400 microns from the muscularis mucosa is SM1 and there was no lymphovascular invasion. So that is one of the main reasons for performing ESD, is that when you, in an unsuspected lesion, you find cancer as you did on the left side, which was a flat lesion, still had cancer in it. Now you have cancer at the lateral margins. He can't tell you how deep it is. The decision-making process is very difficult. Both cases, we managed to achieve complete resection of neoplasia. That's not a problem. The problem is how to make a decision to go forward in these cases. Now, one of the other things I want to highlight, this is a very good data where the Amsterdam group measured the amount of submucosa you get in the EMR specimen. So whether you do the cap technique or you do the multiband mucosectomy, with the cap technique, we probably get a little bit more submucosa, but nobody does that anymore. In the multiband mucosectomy, you can see you get between 0.5 to 1 millimeter with a mean of 0.8 millimeter. So this is the maximum thickness of submucosa you get. The whole decision-making process for cancer, when you find in an EMR specimen, is whether the invasion is more than 0.5 millimeter or less than 0.5 millimeter. If your submucosa is only 0.5 millimeter, how is the pathologist going to tell you it's more than or less than? So again, that is another reason why when you suspect cancer, you should be thinking about ESD to get that good quality specimen. What do the guidelines say? Now, these are the old guidelines of ESG back in 2015, which has just been revised, and it will come out within the next 3 months, and there'll be a lot of changes in it. But these old guidelines did suggest that EMR for visible lesions is in Barrett's esophagus with a curative intent remains the mainstay of treatment. And ESD can be considered for selected cases for lesions more than 15 millimeter, poor lifting, and lesions at risk of submucosal invasion. Now, the views are beginning to change and these guidelines will change, but this is where we stand for now. So what do we do in Portsmouth? We started doing ESD in Barrett's back about 2011 to 12. And the protocol we follow is very, very simple. It is a morphology-based decision we make. If you have a visible lesion in Barrett's, and if it is a 2A flat lesion, 2B or 2A lesion, we go for EMR. I would say nowadays only for 2B. If it is a 1S or 2C, we would go for ESD. All of them will obviously get RFA. If it is not visible at all, then they will get RFA, which is a rare situation, but does happen. If you follow this, you can see that we were selecting the patients quite rightly for our ESD group. 83% of these patients had cancer. So not all nodules have cancer in them, but as you can see here, that 83% of them turned out to have cancer in them. So it is about lesion selection and choosing the right case for the right technique. How do you do it? This is our classical technique for ESD. It's a large nodule. This is certainly not for EMR. So use your best possible imaging technique. We use acetic acid here. The lesion looks quite ugly. We mark it just how you do with EMR. And then once you mark the lesion, you do your mucosal incision. You can see here, you can use a viscous solution these days. A lot of viscous solutions are available. So use that, or jelly fusion, which we've used in this case. And then you start your mucosal incision. And in the classical technique, you would do a complete circumferential mucosal incision, either at the start, or you keep on increasing your circumferential mucosal incision as you dissect. You can see here, we managed to isolate the lesion completely and then dissect underneath till we can achieve a complete excision. The cap is extremely useful here. It's the cap which is giving us the traction, because these patients are anesthetized. We can't keep changing the position, unlike what we do in colon. So without the cap, this will not be possible to achieve a nice traction. See the planes. We can see all the markings are gone. The lesion is out. And this will now get pinned and sent across to the pathologist for reporting to get the correct histology on them. Increasingly, since POEM has started, more and more ESD, especially in esophagus, is being performed with tunneling technique or pocket creation technique that we use in colon. Here you can see very ugly looking nodule in an otherwise good looking Barrett's. We perform a mucosal incision. Once you have a mucosal incision wide enough, we will perform some mucosal dissection in the same area and keep digging underneath it. We don't perform the mucosal incision on the side. We just go under it and we make a tunnel. We keep going there. You can see a nice big pocket with very good traction. This gives very nice traction and opens up the planes. Once this is done, the next is to perform a retroflexion here and open up on the stomach side or the anal side of the lesion. Now we're doing it in retroflexion. Here you can see already the tunnel is open on the far side, few strands left in the middle. Once that is done, there's a nice tunnel all the way now. Now you can use a simple device like this, a scissor device, where you can grasp the side margins and resect them, or you can carry on using the same knife which we're using at the start, and you can resect it. So different ways of doing the same thing, but ultimately achieving the same outcome is an en bloc excision, very nicely taken out of a large, ugly looking nodule. We especially do that when we think that the lesion could be deep, and when we are not sure, then the safe technique is to use the tunneling technique. Here is the data, which is one of the largest ESD series reported so far between 4 centers, between the 3 centers in Europe, looking at mainly the safety. The delayed bleed rate was low, stricture rate was surprisingly low, and perforation was, none of these patients had perforation, which looks very good. The main conclusion of this is that ESD in expert hands remains a very, very safe technique. However, the R0 resection rate was around 80%. This is the data of all the published Barrett's ESD series so far, and you can see that the outcome, technical outcome, looks good apart from the R0, which remains around 80%. And there are a lot of reasons for that, and we can discuss as we go toward in our discussion time. Here is the meta-analysis from Peter Draganov's group, where they showed exactly the same thing, that most expert centers are not doing ESD for these 2B lesions. Very few of them are being taken for ESD, so because they can be very adequately treated by EMR. The procedure time, which is talked a lot about, remains an average between 80 to 120 minutes, which I again think if you have a cancer in your esophagus, that's not a lot of procedure time, and it should not be an issue in deciding what technique to use. It remained safe again. The adverse event rate in this meta-analysis, you can see here, again, its delayed bleed rate and perforation rates are very low. The stricturing rate was 11.6%, which is again an acceptable stricture rate, and that's what you would see after, especially these are generally complex patients who have ESD. There's been a lot of debate whether ablation after ESD will have a higher complication rate than ablation after EMR. So we looked at this and published a while ago, where we found that whether you do ablation after ESD or ablation after EMR, your complication rate and stricture rate is no different. Obviously, if you don't do any resection, then your complication rate is very low. But EMR or ESD doesn't really make any difference in your complication rate with RFA. So RFA remains perfectly safe after EMR or after ESD. There's not a lot of randomized trial. This single trial with very small number of patients showed that the R0 rate in EMR patients was low as expected, but in ESD patients, the R0 was high. But otherwise, they reported a 10% perforation rate in the ESD, but the number of patients treated were very low, only about 18 patients. So it's very difficult to make out. And I feel that based on that study, we should not make up our mind, because there are a lot of issues. The lesions, they were all 15 millimeter. These are the lesions which you would not consider mostly for ESD. The study was only powered for R0. So again, commenting about anything else, will not be a good idea. And it did meet its endpoint. It's a positive study showing the ESD does show a higher R0 rate than EMR. So I think we need better quality data here, and there are a few ongoing trials which will address it. Finally, the important thing is to make a decision. And I think there's an increasing consensus that SM1 invasion, which in Barrett's is defined as invasion below 500 microns for muscularis mucosa, is SM1. And if you have no other poor prognostic factor, then the risk of lymph node metastasis is very low, and these patients could potentially be considered for a conservative follow-up rather than subjected to any other form of radical therapy. There are some challenges. As I said, Barrett is an inflammatory condition. It's very vascular. The most annoying thing with ESD in Barrett is the intra-procedural bleed, not the delayed bleed. Look, when you get a bleed like this, it's very scary. It's coming from top of the muscle. You use a core grasper, which is a monopolar, or even if you use a bipolar device, you're sitting right above the muscle, and there's a risk of perforation. So its a preference would be to use a bipolar device here, but still there's a big risk of perforation. Another case, you see here, it's coming from the muscle fibers. You're almost grasping the muscle fibers. You need to be very precise. I'm not very happy. It's not precise. So you need to open and catch again. Water jet. Now I'm very sure that I've got the bleeding point, and very, very gingerly you cook just enough to stop the bleeding, but not to make a perforation. That's a very fine balance between controlling the bleed and avoiding the perforation. So this remains a challenge, and we need to think of better solutions. We use this Purostat a lot in our practice for intraprocedural bleed. You see here, you got a bleed, you can use diathermy, or you can use a gel like that. You can see through it, and it stops the bleeding right in front of you there. And you can then carry on with the ESD because the gel is transparent and it doesn't interfere with the continuation of ESD. So it does help to have solutions like that. Although if heat is safe, there's nothing better than heat to control the bleed. You now have newer agents who can do the same thing. That's the next powder from Medtronic. And you can see here, it's being deployed. As soon as you deploy, it reacts with the tissue fluid or with the blood, and it forms these complex bonds and results in formation on an adhesive gel, like a mechanical barrier on top of a bleeding point. And that mechanical barrier basically plugs your bleeding point and stops the bleeding. So this is another addition to our whole bag of tools that we have. The delivery system is very, very simple, comes with its own gun. You plug in the tube with the next powder, and it's very, very easy. The big advantage of this next powder is that when you start inserting the catheter, you switch on your motor, and that fires the air throughout. So that stops fluid coming into the catheter and clogging the catheter even before you use. And that we have seen with other powders like this, that the catheters can get blocked. In my experience, we've never had a situation where the catheter got blocked. So that's a huge advantage, because the last thing you want is the catheter getting blocked when you arrive at the bleeding point. Here it shows you clearly how when you spray immediately it forms a gel, which is translucent. And if there's a bleeding, you should be able to see through it. On the right side, you got a bleed in a resection base. Clips have been applied, but the bleeding hasn't stopped. You fire the powder and the bleeding has stopped. And you can see that once, if you go forward there, this is the following day, and you can see the powder is still there and there's no more bleeding. The clips and powder are there. So it does work and stop your bleeding when you need to. Things can also go wrong. I can't show you any perforation video in Barrett's esophagus, as fortunately I haven't had any perforation to patch up in Barrett's, but this is a similar situation in stomach. an ulcerated lesion healed, ESD being done here. You can see the fat already there. Our endoscopist has still not seen that this is a perforation and tries to inject and makes it very, very obvious that this is a perforation. Don't panic. All we need to do is dissect around it. Just take the submucosa away from there and make space around the perforation. If you're using CO2 and patient is under GA, you have time to do that. So just release the submucosa and make space around that perforation. Once we have the space around the perforation, put a single clip to hold this perforation together. Once this perforation is brought together with a single clip, you need to speed up now. So we're using a traction device, clip and line, and with this we can speed up and then finish the procedure and then close the perforation. Way forward, there are better devices now. You have this large lesion in Barrett. It's a multifocal cancer in Barrett. You can see here 2C depression. It looks ugly. There are 2 other foci. In the speed of time, I will just speed it up. We mark the lesion and you'll see this is the switch knife from Medtronic, which appears like a needle there. You change and now you have a ceramic ball on the needle. And so you can use it as a needle like this or with the ceramic ball. So that's why it's called a switch knife. We use the needle here to perform the mucosal incision. Because it has that ball in front, knife is a little bit thicker. It has got very good electrical properties. So in my experience, the coagulation effect that you get with it is a lot more than the other knives. So you encounter less bleeding and oozing during the procedure, but you need to be careful that it will deliver a bit more coagulation current. So you need to tailor your technique to that. Here you can see now we injected a viscous gel like Eleview, and then you use the needle technique. We've now done almost all the incision from the oral end. We now change over and do a retroflexion. This is where the switch knife is very useful. You now are almost at 90 degrees to the muscle. You put your ceramic cap on top of the needle, put it straight towards the muscle, hook it in, and see you go without any fear of making a perforation. Now, this is a cardia where we encounter a lot of vessels. This knife, being a long needle, a thick needle, has got very good coagulation properties. Ideally, otherwise, I would have coagulated those vessels before cooking. But with this knife, I go straight with my swift coagulation and coagulate those vessels rather than use coag-grasper. So once this has been done, it's released from here. We will now use a traction to just lift it up there, clip and line again. And now we can again just use the knife. Once you have a traction, we can use the needle type, or you can use with the ceramic ball and very quickly and easily dissect the lesion. Here, the lesion has been dissected completely. Quite a big lesion in a long segment of Barrett, successfully achieved without any problem with the switch knife. And I think you will see increasingly more and more people will use this knife, but does require a lot of training to use it. Finally, to finish off, I haven't used the device in the Barrett, just haven't had a case. So I'll show you, this is an early gastric cancer. Again, we're using the switch knife to mark it and then open it up. Once we have opened up here, we're using the Eleview again. Once you inject, you don't need to go back and inject and re-inject again. You'll see here that we have done a circumferential mucosal incision. Once we have achieved a circumferential mucosal incision of the lesion, I want to improve the traction. We're using this Prodigy traction wire from Medtronic. It is a clip with this metallic traction wire. So we fire the clip, which catches the mucosal edge. And then we have this metal loop, which is designed in a particular shape. So you catch it with another clip, which comes in the pack, and then you attach it to the opposite wall, a little bit on the distal side. And as you inflate the stomach or the esophagus or the colon, you automatically get more tension. And more traction. So you can control the amount of traction you want by inflation and deflation. You see the traction? Beautiful traction now. Now ESD will be very easy. You just need to drive the knife in this beautiful submucosa which has been exposed in front of you and achieve a complete excision very quickly. So not only does it make it safe, but it makes it a lot quicker to do the ESD. And finally, to finish off, you can put next powder on top of the base to reduce your post-ESD delayed bleed rate, especially in the stomach where it remains very high. So it can be very, very beneficial there. I won't, for the sake of time, I won't show, but ESD is pushing the boundaries. You can do post-radiotherapy, post-esophagectomy, all kinds of situations. ESD can be a salvage procedure to resect these really difficult situations. So finally, I think when they look suspicious like this, they are cancer, you should use the knife. If they are flat lesions like this, the risk of cancer is very low and there is no need to get the knife out here. I think we can discuss training in ESD during our discussion. So to save time, I'll go through it and conclude that ESD in Barrett remains very safe and you're going to see more and more ESD happening in Barrett's. We get much better devices available, which improves the safety as well as the speed. But the debate between EMR and ESD will continue till we'll get some good quality data. Thank you very much. And I'll stop.
Thank you, Pradeep, for a real action-packed lecture covering not just endoscopic submucosal resection, but also the use of this new exciting hemostatic powder. So let me kick off just quickly about the this new knife that you showed. The concept is very nice. Is one able to inject through this knife?
No, not in the current version, but the subsequent version of this knife, you'll be able to inject. So I would suggest if you are using this knife, go for a viscous solution, and then you will need to inject very few times. So just inject a viscous solution, and then you can just carry on cutting.
Sure. Dave, let me just bring you in on the on next powder, because, as you know, we've got a bit of experience, as does Pradeep, obviously, in looking at these hemostatic agents that are applied topically. First of all, your observations about what you've seen, and then really, what do we need next as endoscopists in terms of data collection on this? It's a data-free product. What are your thoughts?
Sure. I mean, first thoughts, just very easy to say. What are my thoughts on the product? It looks fantastic. I think it. There's a gap in the market, so to speak, in terms of this sort of tool. Early signs look that it works fantastically, and I think what's really great about it is not only does it form that protective barrier, but it does so in a way that you don't lose visibility with your scope. Whilst you're applying it, which I think is a huge step forward in this. And I think when we're talking about data, there is a lack of data at the moment in terms of next powder, and I think that it's hugely important that it's gathered in the correct way. Medtronic, with the RFA device, have a history of making sure there's great, robust clinical trials backing up their products, so that when we have talks like this or whatever else, we can sit here and say, hey guys, this works, look at this is fantastic. And I think when I think about GI bleeds, we talk about the big studies where you say, right, adrenaline plus clips, you must be done, and these were done in randomized controlled trials where patients were offered endoscopic intervention or one therapy or whatever else. And I think, in my opinion, what's important with next powder is that Medtronic take the data collection very seriously. It'd be very easy to just say, hey, we're going to apply this to everything, be that a post-EMR bleed, a post-ESD bleed, maybe some patients who've got some peptic ulcers or whatever else. And actually, the really robust way of doing it, I believe, would be to actually say, right, we're going to use this as primary therapy in a controlled trial with leading endoscopists in leading centres who are saying these are forest 1, 2A lesions, whatever else. These are These are lesions that need treatment done by experts as primary therapy. And then we'll see truly if Next powder can be used as instead of clips or instead of adrenaline injection, and I think that would be really strong data if that can be gathered.
Yeah, really valuable comments, Dave, about the methodology for collated data. Pradeep, just to come back to you about, you showed a very interesting slide, a historic slide from Amsterdam when CAP EMR and multiband mucosectomy specimens were compared, and just showing how really very little submucosa we sample with CAP-based mucosectomy devices. Now, this calls into question even more your decision making about which resection modality to use based on your decision making pre-therapy, i.e., your imaging and your lesion morphology. Because what I hear you're saying is that actually the majority of lesions that the people on this course who are proficient in endoresection and mucosectomy will be doing are still amenable to endoscopic resection. So these are your flat type lesions, the superficially elevated lesions. The majority of these patients, we won't be under-treating them or under-informing our pathologists with mucosectomy. What I hear you're saying is that there is a subcategory of Barrett's lesions where they are endoscopic high-risk stomata, i.e. they're superficially elevated and with an area of depression, or they are polypoid or subpolypoid where an ESD is advocated. Is that a correct interpretation?
Absolutely. I think that's very correct interpretation, because we can go into big details of magnification and patterns and all those things. But very simple way of managing is the risk of cancer in 2B lesion is very, very low. So don't think, unless there's a very good reason why you want to do ESD, like post-RFA or it's very severe fibrosis, that's a very different reason. Otherwise, there's no need to think about ESD. But all these nodular lesions, your immediate instinct should be they should be resected and block. Depending on the size of nodule, decide ESD or EMR, but it has to come off and block. So I think morphology can help you make that decision.
Yeah, and I think it goes back to the very first lecture of this evening session where David said, this is probably the most important lecture. And it is. It comes down to investing time in your imaging and your lesion recognition, is spending time with people like yourselves. Just very quickly, for the future of ESD in this country, I think we've been slow to adopt it in the esophageal space. I cannot think of more than 2 or 3 people that I know that are doing this in a high volume setting. How do we support those that want to do this, and those that do want to do this? What do they need to do next?
That's a very good point. I think ESD, there should be a difference between enthusiasm and realism. A lot of us want to do ESD. We need to be very careful of our setup, what setup we have, what volume we have. If your volume of resection is not more than 30 to 50 cases a year, then I think you taking that journey, it's not going to be very fruitful. Yeah. Because if you're going to do ESD, you need to do at least 1 case a week of ESD to keep your outcome good and to do justice to the patients. So that's where you start first, that I have the volume, I'm seeing a lot of these cases, how do I now learn? Now, there are a lot of courses around in UK, in Europe, where you can learn on animal models. You then go and visit. But most important thing is spend some time with people who are doing a lot of ESD, not to get your hands on the scope in the patient, but to understand the setup, the decision-making process, managing the issues and the technical challenges that we face when you're doing ESD. And the biggest challenge is the intraprocedural bleed. Once you start getting bleeding, the planes become muddy, you lose your orientation. This is stress in the environment. learn how to manage all that, that's when you're ready. Support, I don't think it's a big problem because there will not be more than 7 or 8 or 10 centers in UK who can sustain a good enough volume for Barrett's ESD. And they can easily all work together. We can support each other. I don't see that as a big challenge.
Yeah, shared learning is paramount. Listen, Pradeep, thank you for that. So, ladies and gents, I'm just going to bring this session to an end. I'm sure we could continue waxing lyrical for many hours, but I need to let these fine gentlemen get back to their families and to their kitchen tables. But a big thank you to both of you, Pradeep and David, for some really insightful and relevant, clinically relevant lectures. I was really pleased to see how little the data there was on your slides, but more sort of practical considerations for us to take back to really help grow our practice and ultimately help our patients. So a big thank you to both of you. Thank you to Medtronic for putting this series of 3 lectures together, and then also the team at Gastro Learning and this fantastic platform that has allowed all of you at home, at work, in your offices to engage. So, with that on board, gents, good night. Thank you very much. I'm sure we'll see you soon. And to all of those that are watching virtually, thank you very much and have a good evening.
Thanks a lot, guys. Great evening. Have a good time and catch up soon.